So there's how many people in this conference? Dr. Kaushik? How many people registered here?
120 plus hours.
120, right. So if this was an arthroplasty conference, there would be about 400, right? Because 300 would be funded by industry. So that's what is happening to the age limits for a knee replacement. Knee replacement requirement is being stretched. Now today, if you go to some of the bigger places doing arthroplasty, I've heard of situations where patient is going in for one side, and while going in, the patient is told, अभी दूसरे साइड का तो होना ही है, तो अगर आप बोलो तो वो भी कर देते हैं, right? For our international guest, it is patient is going in for a unilateral, and patient is told that anyway, you are going to need a knee replacement on the other side. So if you say we'll do the other side also at the same time. So that's where, and today if an young orthopedic surgeon is not doing, arthroplasty, it's almost as if he's, it'll come. There. Right. So if a young surgeon is not doing arthroplasty, it's almost as if his masculinity is suspect. Oh, you don't do arthroplasty. So the question is, why do people not do a high tibial osteotomy? Because they feel that the long-term results of a high tibial osteotomy are not good, and that's just not true. If you look at the literature as far back as early papers done in 1987, they have long-term good results of up to 13 years and more, but at least 13 years long-term good results. And even in recent papers, as recent as 2014, you got definitely long-term good results with a high tibial osteotomy. So there are a lot of different ways of doing an osteotomy, and I'm not going to argue necessarily for or against. I think all of these methods basically are about how to get precise alignment, whether you use an Ilizarov, whether you use a fixator like I do, or you use a Tomofix, which I do sometimes. Most of these papers show that good results are ensured by an absolute perfect alignment. Obesity is a questionable sort of factor in that. Activity level is a questionable factor in that. So what is this adequate valgus? And there are two things here. One is the HKA, hip knee ankle angle, which is normally, we say, if you are between the range of 183 to 186, you are good. And the second thing is what is called as the Fujisawa point, which is nothing but the weight-bearing line passing between 30 to 40% of the width of the lateral tibial plateau. To make it simple, it is somewhere around the base of the lateral tibial spine. If both of these things are met, then you have adequate valgus. So you know the deformity principles that you do your cora and do your osteotomy at the cora. So when you do planning for these kind of patients, you will find that most often the cora comes at around this level, at the level of the head of the fibula. Your bisector line comes at the level of the head of the fibula. So if you're doing a closing wedge, your hinge is on the medial side. If you're doing opening wedge, your hinge is on the lateral side. And there are many ways to do this. As I said, you can do simple closing wedges, you can do open wedge with the Pudu. Flavor of the month at the moment is the Tomofix fixator. What I use is a monolateral fixator for these simple coronal corrections. So there are two proximal pins, there are two distal pins. There is this T configuration, which is a self-aligning clamp, and there is a distraction over there. So we put on the fixator on an intact bone. There are two pins in the T configuration proximally, two pins distally, and then we do the osteotomy in an oblique fashion. This osteotomy is distal to the tuberosity, which is somewhere over here, okay? But it ends at the level of the head of the fibula, which means that the hinging is happening still at the cora. And why is it important? Why do I think it's important to do it distal? Because When you do large corrections, like in a lot of our patients who have got primary tibia vara, whatever correction you do, if you are distal to the osteotomy, you are not going to pull down the patellar tendon. You are not going to create a patella baha, right? Also, when you do these large corrections, because you don't tighten the patellar tendon, you are not increasing the patellofemoral pressure, which again becomes an issue in a lot of our patients. So this is distal to the tuberosity, but it is not complete, and this is aiming at the tip of the fibula. So this is basically, biomechanically speaking, this is pretty correct because it's hinging around there. And this is the difference between the osteotomy, the way that I do it or I talk about it, and the way that the AO Tomofix is. They are both similar in terms of the inclination, both similar in terms of where they end, but the AO talks of a biplanar osteotomy where there is a vertical or a transverse limb which is like this, and there is this part which is behind the patellar tendon. So this is what is known as a biplane osteotomy. Whereas when I use the fixator, it is a purely sort of transverse osteotomy. And at the end of that, I've got an osteotomy which is complete enough, which allows opening, but is not complete in the sense that there is a lateral hinge. So you can do this exactly, you can open this out exactly as much as you want, and it's not a very difficult thing to do. So after 7 days, which is the usual Ilizarov thing, at 1 millimeter per day, patient goes from this, a few days of distraction, you can see that the MPTA from less than 90 has now gone to more than 90, and then as much as is required. So this can be varied according to what the patient needs. So a patient with a leg looking like this in the beginning goes to something like what you see in the center. And at the end of 3 months, 3.5 months, once the fixator is taken off, there is nothing left inside. And this anatomy is as close to normal as you can get. That gap which was there has completely filled up over there. So why am I so sort of enamored of the fixator? With the conventional osteotomy, I am always a little worried about, can I get this perfect correction? Now they have an alignment jig which was not there earlier, but even with that, when you have lateral laxity, it's always a question mark as to how much is the exact correction that is required. And with a fixator, I can get this precision that I need. When you are doing your surgery, you are in a supine, unloaded position, and all your x-rays, etc., are in this loaded position, which has a definite difference in terms of what happens to the joint. So if you find that the patient, you've calculated, okay, this patient requires 18-20 days of distraction, and patient comes back with undercorrection, like in this patient. We calculated needs X days of distraction. When we did the full length X-ray, patient has a midline, but not the 183 to 186. The Fujisawa point is more towards the center than through the base of the tibial spine. With a fixator, it's not a problem. Just keep distracting. And in another few days, you will get your angle what you want, and you will get the weight bearing as you want. Lock the fixator there, patient continues weight bearing. And the reverse. If you subscribe to the theory that medial overloading causes medial cartilage wear, if you overload the lateral side, it is liable to spoil your result in the long term. So even when you get overcorrection like this, where the correction despite calculation has gone way over onto the other side, you just have to do in the reverse direction, and you can get your correction to exactly where you want. So the AAOS says that a valgus producing proximal tibial osteotomy has got a limited, the strength of the recommendation for a high tibial osteotomy is limited. But sometimes you really have to wonder about, how much are you going to base on practical common sense, and how much are you going to base on evidence? Because if evidence was everything, you can't have a parachute, right? There is no evidence which tells you that a parachute will save your life when you jump out of an aeroplane. No randomized control trials. So the Cochrane says that an osteotomy can improve pain and function This is based on changes within a treatment group. No studies comparing osteotomy versus conservative treatment. Similarly, there are no studies comparing total knee replacement versus conservative treatment. Now, this is what I call the brand ambassador for a high tibial osteotomy. This is a surgeon, orthopedic surgeon from Patan, who had a bilateral high tibial osteotomy at the age of 58, which is nowadays becoming, as I said, the age for revision in India. So this was what was my experience. Post-operative pain was not much. From third day, I was taking bath. After 1 month, I was able to operate the minor operations. After 1.5 months, I was able to walk full weight bearing. I was able to do my total hospital work. He did one at a time, right? 2 lower pins never gave any trouble. But out of the upper 2, mainly posterior one takes a little more time to heal, but that's more of because of the irritation from the flexion extension. But this is the best sort of slide. These are actually slides which I borrowed from his presentation. So night pain, disturbed sleep, severe muscle cramps, no muscle cramps, difficulty while walking, unable to squat, difficulty in sitting cross-legged more than 5 to 10 minutes, not able to climb the staircase, waddling gait, as you know, all of them have got this Trendelenburg sort of gait, swelling over both knees, very painful while doing surgery in standing position, not able to drive a car. All of these troubles were completely reversed with a high tibial osteotomy, and he is now about 7 years, okay, post osteotomy. He continues to be exactly the same. And also but this is not a selling point for the osteotomy. I don't say that you will improve your movement, but definitely all the problems of pain will go away, number one. And number two is the accelerated wear and tear which is happening. If you don't do the osteotomy, things are going to get worse quicker, and patient will come up for a replacement quicker. So when you get a 45-year-old who's got medial compartment joint pain, whose medial joint space is reduced, and patient says that I have difficulty in walking long distances, don't tell them कि जब तक चलता है तब तक चलाओ फिर knee replacement कराओ. What you should be telling them is what you should be thinking of is to have a replacement. Now, the other question which people always have is, oh, but if you do a high tibial osteotomy, does the cartilage regenerate? Okay. Now, is the lack of cartilage the cause of pain in osteoarthritis? All of you all, I'm sure, have attended arthroplasty conferences, right? Everybody has attended, even if you are not necessarily doing it. One of the best or one of the constant symposia or panels in the arthroplasty conference is whether to replace the patella or not to replace the patella. 50% of the guys replace, 50% of the guys don't replace, and both of them have the same result, right? So if cartilage loss was the only issue, then you have to replace the patella. But for those of you who don't believe, here is a picture from a colleague, Dr. Manjunath Dharagad, I think his name is, from Hubli, right, Dharwad. So he doesn't, I don't do this, look at the left side. This is a arthroscopy before high tibial osteotomy. Okay, you can see bare femur, fibrillated edge of the medial meniscus, bare tibia. Okay, and this patient, when the patient came back for an osteotomy on the other side, he had an opportunity about 11 months post high tibial osteotomy on this side, and you can see that this, how do I get to this one? I'll just let you see it in a smaller resolution. Point here is that entire surface which was bare is now covered by cartilage. This is not hyaline cartilage. This is fibrocartilage, but it's a high quality fibrocartilage, and this is again something what the results have shown, that when you get a good correction, you have the best quality of cartilage that is developed, and you don't need things like microfracture, etc., For this, it is just the correction of alignment that works. Okay. What is happening? Sorry. Now, there are some other advantages with the fixator, and those relate to no change in the tibial slope, as well as I pointed out earlier, no change with the Insol-Salvati index. Even with severe varus, which we see in a lot of our cases, you can correct this because these are cases with metaphyseal varus. Of course, when you have a multiplanar issue, when there is a flexion deformity along with a varus, or when there is a significant clinically visible internal rotation, then you cannot use this method. Then you have to use the regular Ilizarov method. Now, there is no problem with the doing a few knee replacement also, because the incision related to this is pretty small. Also, if you look at the shape of the tibia, there is no truncation of the proximal tibia as happens with a Coventry kind of osteotomy. So, even if you have to do a stemmed implant, you can use a regular stemmed implant. You don't need these offset kind of stems. And this probably is one of the best statements that I have seen. If you want a 30-year survivorship with a knee replacement, then if you do a high tibial osteotomy first, and then whenever 13, 15, whatever years later, you do a knee replacement, that is the appropriate way to go. We have enough patients who deserve a genuine knee replacement. We don't need to get 45-year-old and 50-year-old into the net of a knee replacement. So finally, when you see a patient with osteoarthritis, you should be looking for medial compartment osteoarthritis. If the patient tells you, I've got pain on the inner side of my knee, and you can see varus like this, the chances are that this is mostly a medial compartment. So you got to consider an early osteotomy, whichever way you may think is appropriate for you. But whatever method you use, you should use adequately precise planning. You should use adequately precise execution of your method. Thank you.
Thank you very much, sir. The next session is on Ilizarov and flexion deformity of the knee management by Dr. Harshad Shah. And as we get ready with the PPT, we can take one or two questions. It's already, so at the end of the session, we'll take questions.
I have one question. I tried to do this in one of my patients. I have done a few after learning from you only. When I put the half pins, they were loose. The proximal half pins in the osteoporous tibia. I changed to Ilizarov.
That's fair enough.
Did you face?
I've not had a problem where the pins were loose. There are certain sort of tips in terms of the direction of the pins and all that. So I've not really had a problem. But there are other questions of what happens if the lateral hinge breaks. Yes, you can change to an Ilizarov. I don't have a sort of fight against this way or that way. My whole goal is think of an osteotomy as not a salvage operation or not as a time buying. It's got its place, which will give you very good results for the adequate length of time.
The next lecture. Maybe one more question. Is there a cutoff, like up to this much of
No,
varus?
there is no, in terms of how much varus?
Varus, no.
With this particular method?
Uniplanar deformity, any amount of varus can be tackled.
Yeah. Meaning if you go beyond a certain limit, you'll run out of distraction. But I've got around that by having distractors which are slightly
Bigger.
longer. So you can do that. Only thing is, if you do a very large correction, you will have to do a fibular osteotomy. In these cases, there is no fibular osteotomy.
And is there-
It just opens around the head of the fibula.
Is there a scope for translation in case the cora is not at the level of the head of the fibula? Maybe if it's a little down.
No,
No.
there is no
So how
scope
do
for
you handle
translation. No, there is no need for
Need for
translation.
translation.
If you are at the level of the head of the fibula, you are more or less correct.
Thank you, sir.
How much correction you can go for acutely with this?
How much correction?
Correction, acutely how much you can do?
Wha-
Gradually you are doing after 7 days, but acutely
Gradually.
you can do?
No, with this I don't do acute. There's no sense,
And-
because if nature
yes.
is going to give me good bone when I do it gradually, why do it acutely?
And when you cut fibula, when you are...
I don't cut the fibula.
fibula.
When I do this, I don't cut the fibula.
Maybe the next lecture. Thank you so much, sir.